to order. Welcome to meeting number 113 of the House of Commons Standing Committee on Health. Before we begin, I'd like to remind all members and other meeting participants in the room of the following important preventative measures to prevent disruptive and potentially harmful audio feedback incidents that can cause injuries. All in-person participants are reminded to keep their earpieces away from all microphones at all times. As indicated in the communique from the Speaker to all members on Monday, April 29th, the following measures have been taken to help prevent audio feedback incidents. All earpieces have been replaced by a model which greatly reduces the probability of audio feedback. The new earpieces are black in color, whereas the former earpieces were gray. Please use only a black-approved earpiece. By default, all unused earpieces will be unplugged at the start of a meeting. When you are not using your earpiece, please place it face down on the middle of the sticker for this purpose that you will find on the table as indicated. Please consult the cards on the table for guidelines to prevent audio feedback incidents. The room layout has been adjusted to increase the distance between microphones and reduce the chance of feedback from an ambient earpiece. These measures are in place so that we can conduct our business without interruption and to protect the health and safety of all participants, including the interpreters. Thank you all for your cooperation. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on May 16th, 2022, the committee is resuming its study of women's health. I would like to welcome our panel of witnesses and thank them for their patience. We have appearing by video conference Dr. Neeru Gupta, professor in the Department of Sociology at the University of New Brunswick. Also by video conference, Dr. Ruth Ann Murray, a professor in the Department of Medicine, Max Rady College of Medicine, University of Manitoba. And with us here in the room, Dr. Deborah Money, professor and the head of the Department of Obstetrics and Gynecology at University of British Columbia, and representing MS Canada, the president and CEO, Dr. Pamela Valentine. Thanks to all of our witnesses for being here. Thanks for your patience as we had to observe the established rules of this place in terms of votes taking precedent and the time allotted to allow for members to cast their vote. We have resources here until 2 o'clock, colleagues. I suggest that we get the opening statements from the witnesses, proceed with one round of questions, and then we'll test the will of the room as to whether we want to go any further than that, but I would think that we should be able to get at least that far without issue. At least I hope so. So with all that by way of introduction, we're now ready to begin with opening statements of 5 minutes in length, starting with Dr. Gupta. Welcome to the committee. You have the floor.
Thank you very much. My name is Dr. Neeru Gupta. I'm a professor of sociology at the University of New Brunswick, and I'm also Equity League with the Canadian Health Workforce Network. And as such, I would like to share with you some of my thoughts on how we can improve women's health research. And in particular, I would ask the committee to consider that ending the neglect of women's health research necessarily entails ending the neglect of research on women in the health workforce. We know that there is no health care without a health care workforce. And we also know that we are experiencing a health workforce crisis. Indeed, this very standing committee published a report in 2023 addressing the health workforce crisis. And yet, like much of health research, that report was gender blind. In other words, there was no mention of women, and there was no mention of any potential unintended consequences of gender-blind or one-size-fits-all policies to recruit and retain healthcare workers. We know that half of the Canadian population are women. We also know that 4 out of 5 healthcare workers are women. And so how health research considers or neglects the health of women in the workforce as both recipients of care and providers of care itself is an impediment to improving health care that works for all Canadians. The Standing Committee on Health has also heard, to my understanding, from various speakers before about a number of persistent research limitations in terms of better understanding the health of women, in particular in relation to health conditions that are specific to biological females, such as ovarian cancer or menopause. Those health conditions with risk factors, symptoms, or modifiers that more often go under-recognized in women, such as heart disease, or those that might disproportionately affect women because of a multitude of sociocultural factors, such as depression or intimate partner violence. All of these issues, therefore, also affect 4 out of 5 healthcare providers. And a double impact is the neglect of research on women in the healthcare workforce itself. So while healthcare services and health research are often considered insufficiently responsive to women's specific health needs, they're also highly dependent on women as providers of care. And yet, analyses of the impacts on women, gender-based analyses, are much less prevalent in research and in research funding opportunities on the health workforce and the associated implications for healthcare improvement, including improving patient experiences, improving the health of populations, improving value for money, and improving healthcare provider experiences. That last dimension is implicit in the quadruple aim, which has been adopted by healthcare organizations across Canada and around the world. And yet, women's experiences as healthcare providers are understudied and undervalued. Research is scarce on how factors salient to women drive health workforce outcomes. We know that in Canada, as indeed in much around the world, data to support research and policy on the health workforce tend to be siloed and incomplete. The Standing Committee on Health has already endorsed the need for better, more robust, and comprehensive health workforce data to help address the health workforce crisis. This includes sharing and use of comprehensive workforce data as part of a world-class health data system, as identified in the Standing Committee on Health's previous report. The recent establishment of Health Workforce Canada offers a valuable opportunity to strengthen collaborative work on health workforce data and planning. Optimizing women's contributions and research on women's contributions to the health sector must be central in these conversations. And so I would ask the federal government, what is the role that we can play to help improve Canada's health care system through improving gender equality? I would argue that prioritizing research investments on women in the health sector is essential to making healthcare work better for women and for all Canadians. Closing the gap on women's health research includes scaling up research on women in the health workforce. And in particular, to borrow a framework from the World Health Organization, I would suggest that there are 4 main areas where we can work together to help improve women's research. Research on women's health and research on women in the health workforce. And these are gender occupational segregation. We know that 4 out of 5 healthcare workers are women. Integrating gender science into health workforce research, therefore, is imperative to disentangling occupational segregation. That is, unequal distributions of women and men within particular job types. If our goal is to increase the numbers of practicing healthcare providers in Canada to help address the health workforce crisis, then we must be driven through research that helps to disentangle and understand gender norms and stereotypes.
Dr. Gupta,
so that
if I could get you to wind up, we're a bit past time. You'll get a chance to expand upon your opening statement in response to questions, but if you can just bring it to a close, please.
Okay, so I would just suggest then that pay gaps, leadership, gender occupational segregation, and safe environments for women are in the health workforce are themselves critical to improving the health workforce, and yet research is lacking.
Thank you, Dr. Gupta. Next, Dr. Mary from the University of Manitoba. Welcome to the committee. You have the floor.
Thank you to the chair and the committee for the invitation to present today about the topic of women's health research. I'm a neurologist and, as you heard, a professor of medicine and community health sciences at the University of Manitoba, where I hold the WA Family Chair in Multiple Sclerosis. I also serve as the director of the Provincial Health Program for Multiple Sclerosis. For the past 20 years, my clinical practice and research have focused on people living with MS, including the topic of women's health. 3/4 of people living with MS, 3/4 of the people I care for are women at all life stages. Today, I will share key reasons why research related to women's health is a critical issue for women with MS and other chronic diseases that must be addressed. First, women with MS must manage the challenges of decisions regarding family planning, pregnancy, and menopause while concurrently managing a chronic disease. Second, many knowledge gaps exist regarding women's health in the context of MS and chronic disease. Third, existing knowledge tells us that women with MS experience important disparities related to women's health. Allow me to elaborate on these points. MS most often presents between the ages of 20 and 40 years. However, it can present in children, in about 5% of people, and in later life. This means that women with MS are dealing with the disease at a time when they are completing their schooling, starting careers, building relationships, and planning families. They must make complex decisions about stopping or changing their disease-specific therapies if they decide to have children, figure out how to parent or sustain relationships while potentially dealing with pain, fatigue, depression, as well as physical or cognitive impairments. In a recent review of the world literature, we found that relatively few studies, about 350 out of more than 100,000 publications, focused on the topic of women's health in MS. Most of these studies focused on pregnancy. Very few studies address menopause, a life stage which all women experience if they are biologically female, gynecologic cancers or cancer screening, or biologic effects of sex hormones. The participants in these studies did not fully represent all women with MS. Most participants were white. Few were living with severe impairments due to their disease. Focus groups have told us that these topics, menopause, cancer, as well as sexual dysfunction, parenthood, and pregnancy, in the context of chronic disease, are the top priorities for future research. Women with MS, like other women with physical impairments, are less likely to undergo cancer screening tests, such as mammograms or Pap tests. This is particularly true for women of lower socioeconomic status. Some of these disparities reflect the difficulty finding healthcare providers and health systems equipped to deal with women with physical impairments, who may not be able to stand unassisted for a mammogram or who need a lift to transfer them to an examination table. Women with MS, as a consequence, are more likely to be diagnosed because they have symptoms of breast cancer than through cancer screening. They are also less likely to survive breast cancer. We need far more research addressing women's health issues in women with MS and other chronic diseases. Women with MS deserve to know how their reproductive life stages and the related biological, sociological, and social changes interact with their disease, how best to manage these life stages and their chronic illness together, and to have effective, accessible care regardless of health status that ensures they get equitable health outcomes. That research must be inclusive, reflecting the perspectives of women with many different characteristics, backgrounds, and life experiences. Thank you for your attention.
Thank you, Dr. Mary. Next, Dr. Money from the University of British Columbia. Welcome to the committee. You have the floor.
Good afternoon, and thank you for the invitation to speak with you today. There are many strategic documents that have been developed in Canada and globally since the recognition of the importance of sex and gender-based research into many conditions, including, as mentioned previously, cardiovascular diseases, cancers, metabolic diseases, mobility issues, including sports-specific studies, infectious diseases specific to women, mental health conditions, and conditions of aging. In addition, as previously mentioned, there are very specific conditions including gynecologic and breast cancers, menstrual cycle disorders, endometriosis and pelvic pain, management of fertility, preconception, pregnancy, postpartum, and finally menopause and postmenopause. This is a daunting and entirely incomplete list of conditions that have only been partially addressed through attempts to increase women's inclusion in clinical trials, cohort studies, and female-specific approaches in fundamental science. In addition, the disparities in Canada experienced by rural and remote populations, Indigenous peoples, and those experiencing poor socioeconomic challenges are amplified in the women's health space. So instead of bombarding you with more statistics, I'd like to share 3 specific anecdotes from my experience as a women's health researcher. My first example draws on my experience where I had the privilege of participating in a bold trial studying the impact of the first licensed HIV drug, AZT, in pregnancy in a placebo-controlled study. The interim analysis came out in February of 1994, and we immediately received the data in our clinic showing that the transmission rate of HIV from mother to infant was only 8% in the treatment group compared to 25% in the placebo. This was the first demonstration that HIV drugs could be used for treatment as prevention and was an extraordinary moment in medical research and globally pivotal. I returned to Canada in September of 1994, and we launched routine antenatal screening for HIV and standard treatment to prevent transmission of this then deadly virus. And I was forever convinced of the value of pregnancy-specific and women's health-focused research. My second example is that of the HPV vaccine and HPV screening towards elimination of cervical cancer. The discovery of the HPV virus as the near universal cause of cervical cancer was not only pivotal for women's health, but brought us to the opportunity to have a vaccine-preventable cancer. Despite major advances in understanding the biology and how to prevent this disease, it continues to kill relatively young women worldwide 1 every 2 minutes, and still more than 1 death per day in Canada. Canadian research has, however, contributed to understanding the 2 key strategies, vaccine programs and HPV screening instead of pap smears. This is a proven strategy, and we've just deployed it in British Columbia and will hopefully move across the country soon. This is a research success story that has driven global strategies from Canadian-based research. Thirdly, an example from our recent pandemic experience. You will recall at the beginning of the pandemic, most focus, probably appropriately, was on the general population and vulnerable elderly. However, we didn't know what would be the impacts on women, the pregnancy, the fetus, and the newborn infant. We were able to pull together many experts across Canada to form a network to study this. And our data showed that pregnant women had a substantially higher rate of hospital and ICU admission and preterm birth rates. This immediately informed clinical care, and when the vaccine became available, Dr. Theresa Tam recommended specifically offering pregnant women the COVID-19 vaccine to prevent these adverse outcomes. Now our data shows that not only is the vaccine safe, but that adverse outcomes are substantially reduced in vaccinated versus unvaccinated women. The key point here is that without Canadian teams ready and able to pivot to study diseases in women and in pregnancy, we would not have even appreciated the substantive differential effects. Finally, I would like to propose some recommendations to move women's health research forward in a strategic and focused way. I believe we need to develop a strategic plan for women's health research in Canada. And part of that, in my opinion, is that we need to invest in key scientists who will focus on women's health research by creating more salary awards for scientists and clinician scientists. We ultimately need to break down barriers between provinces to share data and understand cofactors. To conclude, I would like to quote the Ambassador for Women's Health for the UK, Dame Leslie Reagan. Quote, "When we get it right for women, everyone in our society benefits." Thank you.
Thank you, Dr. Money. And last but not least, representing MS Canada, Dr. Valentine.
Good
Welcome.
afternoon.
You have the floor.
Good afternoon, and thank you to the chair and members of the committee for the invitation to speak today on the topic of women's health. I'm a trained neuroscientist and have the distinct honor of serving as the president and CEO of MS Canada. I'm here today to share the importance of prioritizing investing in women's health research, and specifically for the community I represent, those impacted by multiple sclerosis. As you probably know, Canada has one of the highest rates in the world, and MS is a disease that differentially affects Canadian women. Women are, as you heard from Dr. Mary, up to 3 times more likely to be diagnosed with MS than men. And 12 Canadians every day in this country are diagnosed with this disease. An average of them will be 9 of them will be women. That means that every 2 hours in this country, somebody has to hear you have MS. MS Canada is committed to changing the face of MS today and tomorrow. We're making incredible progress towards our impact goals of advancing treatment and care, enhancing well-being, understanding and halting disease progression, and ultimately preventing MS. We have cultivated a network of MS researchers that have become leading contributors to discovery in the field of MS. The Canadian MS research community is made up of remarkable clinicians and researchers who are contributing to accelerating our research progress in MS, including Dr. Ruth Ann Mary, who you've already heard from today. And as you've heard from Dr. Mary, there's a pressing need for research focused on women's health issues in MS to address health disparities, knowledge gaps, and decisions for MS disease management around family planning, pregnancy, and menopause. I would like to speak for a moment about the emerging area of research which is gaining momentum in the area of prevention. Breakthrough research has shown infection with Epstein-Barr virus, or EBV, as an early trigger required for MS development. This discovery has given us an unprecedented opportunity in preventing MS. For Julia, a mom living with MS, this research could directly impact her. As she says, a parent living with MS, the possibility of my kids developing MS weighs heavily in the back of my mind. It was a question that her and her husband, Matt, had for the doctors when they decided to try and start a family. Could our children develop MS? Is it hereditary? These recent research advances are changing the way we think about MS. Where MS prevention was once a distant aspiration, today we see prevention as an attainable goal. To reach that goal, for moms like Julia, we need to maintain the momentum of these recent discoveries and accelerate research. At MS Canada, we know the power of collaboration. The experience and expertise within the MS research community here in Canada and around the globe working together will lead to transformative progress. Together, we will be able to turn our vision of a world free of MS into a reality. With your work here at the committee and as parliamentarians, you can help raise awareness and propose concrete actions, particularly as it relates to MS prevention. This is a particularly important when assessing the individual and economic burden of MS. A recently released Deloitte Access Economics report estimates the annual cost of MS in Canada at more than $3.4 billion and rising. Please allow me to give you an example of this burden. Amanda was diagnosed just 10 years ago, says, "There is no question that living with MS is costly to an individual, but the productivity lost and the healthcare cost affect our economy as well. As a 36-year-old woman living with MS on long-term disability with increasing health costs, I am one of 90,000 Canadians already costing our system. The toll MS has on our economy is why research for prevention is imperative for our government to invest in. More Canadians are being diagnosed every day, and Canada leads the rates of MS globally. We should be taking the lead in partnering globally to research why MS has become Canada's disease. The federal government has an important opportunity to invest $15 million in MS research, funding in partnership with MS Canada, leveraging our connections and expertise to focus and further our understanding of MS, pursue leading-edge research on repair and regeneration, and explore strategies to prevent MS, such as risk factors, understanding preclinical MS, and develop and test interventions to prevent MS. With just less than 1% of the current federal health research dollars being currently earmarked for MS research, this is simply too little for Canadian women suffering from this life-altering disease, a disease that could arguably be prevented. In closing, we would like to reiterate the urgency of investing in women's health research, which will benefit all Canadian women, including those who live with MS. Thank you.
Thank you, Dr. Valentine, and thanks to all our witnesses for their opening statements. We're now going to begin with rounds of questions, starting with the Conservatives. Ms. Goodrich, for 6 minutes, please.
Thank you, Mr. Chair, and thank you to all our witnesses for being here today. It's, I think, very fitting that we're here in May, the MS month, and have two witnesses to come and speak to us on MS. And I've been shocked every time I think about MS and the fact that 3/4 of the people that are diagnosed are women. So I'm going to perhaps pass it over, Dr. Valentine. How many people in Canada have MS, and how many of them are women in the pure numbers?
So currently we can estimate that the number of Canadians living with MS is 90,000. That might be an underestimate given that there's likely to be individuals in the country that don't get diagnosed. It's often a fairly complicated path to getting diagnosed, and as we know, many people, it takes years. We also have come to understand that there is a prodrome or a preclinical state which we can see individuals with a distinct health utilization pattern as many as 5 to 10 years out before the state of diagnosis.
Wonderful. Thank you. I appreciate that. And Dr. Mary, I was really taken aback by your statements regarding the screening for cancers and the lack of research when it comes to women with MS. And I was just wondering if you had any recommendations about how we could improve guidelines or research to be able to improve those outcomes.
Thanks for the question. From a care standpoint, we need to consciously ensure that the tools or systems we have in place to allow people with physical or cognitive impairments or who live remotely can access things like mammograms and pap smears. So we need to ensure that every community has access to mammogram tables that are adjustable for people who need to be in wheelchairs, and that there are lifts for people to do that. So I think that's an inventory that could be done within health authorities across the country. And so there shouldn't be disparities because you have those impairments. From a research perspective, our challenges have been is that like much research done in Canada and around the world, the people we end up including in studies are those who are best educated, most affluent, able to miss time from work and those kinds of things. So we need to be able to fund studies that are more complex so that we can reach out to people in their first languages rather than the languages they acquire when they come to Canada, so that we can have study sites that are remote from academic centers that still allow us to collect information and to be able to address the barriers of underserved populations so that we can figure out how to address their needs from a healthcare perspective. And that really requires a concerted effort across all levels of funding.
Thank you. As a rural and remote member of Parliament, that's something that definitely does speak to me. And I think that that's an incredibly important piece. Dr. Money, you also touched on rural and remote, and you talked about the HPV screening that is being done in British Columbia, and I was wondering if you could expand on that. I don't have much time left, but I was wondering if you could expand on what's being done in BC, what you would recommend to women, and what you would recommend to other governments when looking at HPV specifically.
Thank you for that question. We have really good data that shows that primary testing for the virus that causes cervical cancer, the HPV screen, is actually better than the pap smear, as much as we were very proud of that from before. And what it does in the way we've deployed it is it's actually a self-swab that is very simple for women to do. They can do it in their home. They can mail it into the central laboratory, and it really does reduce those barriers. So if it's fear of having these kind of examinations, history of trauma, very remote, any of those barriers that have made it difficult for women to get in for pap smears, we are confident that that will reduce those, and we'd love to see it rolled out across the country.
So how complicated is the self-screen for HPV self-screening?
Well, it's actually really very simple. It's a simple vaginal swab, and the labs, almost all the labs across the country are capable of doing the HPV screen panel, and we're looking specifically for types of virus that are known to be cancer-causing. And then it triggers an algorithm for those that are negative. They can go for a 5-year gap. Those that are positive then need more additional attention, but we're then focusing that on the people most at risk of cancer.
That's actually really interesting. I found what you were talking about when you were talking about your research, your early research into the HIV drug and pregnancy, and finding some of those links. I know we've heard many times in this committee through studying the women's health how there's a disparity when it comes to research for that period of time. And I was wondering if you have any suggestions as to how we could improve getting access to women's health research funding, specifically for women in those stages of life.
You know, I think it's really how research funding is allocated and prioritized. We certainly see that pregnancy is often the stage of life where women are excluded from clinical trials. The reason I called this a bold trial is it was incredibly groundbreaking to have the guts to try an early stage drug. But it was because of the high rate of infection in the infants and the death rate associated with that. So it was sort of forced a really bold and advanced move. Unfortunately, we haven't seen that follow up. New medicine, new vaccine, over and over again, we're not seeing the trials in pregnancy early enough to understand safety.
And Chair, I know my time's elapsed, but I have one quick question. What would you recommend to young girls that are looking at getting an HPV vaccine?
I would say, please do it. It can prevent cancer.
Thank you.
That's a good question.
Ms. Sidhu, please, for 6 minutes.
Thank you, Chair. Thank you, all the witnesses, for being here. My question is to Dr. Gupta. Dr. Gupta, I hosted today the Silly Canada breakfast this morning, and they mentioned that the women are far more likely to have a celiac disease more than men. Same thing today, MS Canada, Dr. Valentine, you said women are 3 times more to have MS than men. So given your extensive research, Dr. Gupta, have you found barriers to healthcare for women than men, if you find it? Also, can you give how women are different to detect for the detection and the prevention than men?
Thank you very much for your question. So I do want to preface that I'm not a biomedical researcher. I'm not a clinical care researcher. I'm a social scientist, and we bring a bit of a different perspective, perhaps, than some of the other witnesses that have spoken, certainly today and in some of the other sessions that I watched online. So my perspective is that gender itself, one of the big contributions of social sciences to the healthcare research field is disentangling gender from a sociocultural angle versus that biomedical or clinical angle. And absolutely, we know that there are health conditions that are exclusive to biological women, and we know that others are understudied in women, and that's often rooted in the power dynamics associated with gender, and that power dynamic then extends across the field from undervaluing research to undervaluing women as scientists to undervaluing social science perspectives of how we can improve healthcare and improve access to healthcare services across the genders. The barriers themselves, and I'm speaking also as somebody coming then from a more rural-dominated province, half of our population is rural itself. These are all intertwined with the ongoing healthcare crisis, and yet the conversation around women being the majority of healthcare providers is itself absent from many of our discussions on improving access to healthcare for all Canadians. So I would suggest that if we are looking to improve access to healthcare, that means improving and reducing the barriers to women accessing healthcare occupations. It also means reducing barriers, unconscious or consciously, against men for entering into predominantly female healthcare occupations itself.
Thank you.
And understanding how the dynamic works in rural areas, completely under-researched and without any type of dedicated funding structure to look at this.
Thank you. Over to MP Briere.
Madame Briere.
Ms. Briere. Dr. Gupta, when you gave your introductory remarks, you spoke of 4 objectives. These are 4 objectives that are internationally recognized. Could you continue talking about that, please?
Merci beaucoup. Merci.
Thank you very much for the opportunity to elaborate on that point. That is the 4 objectives. This is a framework that was developed by the World Health Organization. This framework puts a focus on these 4 things. So we're talking about segregation here. That we know that 80% of healthcare workers are women. This is also the result of differences within the profession. For example, there are surgical specialists, and most of those surgeons are men. Most nurses are women. If we wish to increase the number of healthcare workers overall, we need to look at ways how we can simultaneously help women enter the profession and enter specialized roles, but also encourage men to become nurses, for instance. Second off, we're looking at safe environments for health workers that'll help them work in this in the healthcare system. We know that women are more likely to experience workplace violence and domestic violence, but we don't have any way across Canada to establish hard data on whether women are actually safe in the workforce. We need additional research in that direction. This not only has all kinds of ramifications for women's health and healthcare workers, but it also has impacts on the system at large. Third off, we have pay gaps. When we look at in the States, for instance, rather, within the healthcare system, women still make less than men. There are disparities and pay gaps that remain between men and women in the healthcare system. We need to ask why. Is it because of the pay structure? There are other factors that are different. We need to look at these. If we wish to increase the number of women working in rural areas, are they really looking for or rather, would money be a good way to bring them there, or would other things be relevant in this case? I'm looking at daycares, for instance. There's no way. Thank you. There's no way funding. Thank you, Dr. Gupta. Continuing on, Ms. Larouche for 6 minutes. Thank you, Chair. This is a very interesting conversation. It's great to hear from the witnesses today. We've talked about a lot of things. A lot of things have surfaced this week in our discussion with various witnesses. Now I would like to ask a more research-oriented question to Dr. Money and also Dr. Mary. Either one of you can answer this. Earlier, I was at the celiac event with Ms. Sidhu, and we heard that the key is research. Research is key in order to reduce gaps, health gaps between men and women in terms of how services are delivered and more. Earlier this week, there was an announcement after more than 20 years for grants for post-secondary and doctoral students hadn't progressed in any ways. I'd like to highlight the work of my colleague, Mr. Blanchette-Jonca, who at the Science Committee and as science critic was able to help increase grants for doctoral and postdoctoral students and researchers. This is a considerable advance for research. How has the underfunding had an impact and not increasing the grants? How has underfunding and not increasing these grants had an impact? And what kind of impact has this had on the discrepancy of the lack of research between problems affecting men and problems affecting women? I asked the researchers to answer, but anyone can answer if they wish.
I'm happy to start. I'll try and be brief, but I think what's happened is that research funding has not emphasized the lifespan of women who are living with these different disorders that need to be studied. And that's a granting a project challenge, but the piece that I think is also very much a challenge, as much as it's wonderful to hear additional funding for trainees, we actually have a great deal of difficulty with the way we fund research faculty is young and mid-career faculty that are often women coming up into this world are not well funded. It's hard to get funding for them, and it tends to be, not uniformly, it tends to be women researchers that will prioritize women's topics, even within diseases like MS or celiac and so on. So I think we really need to have a look at proportionality and the way we support investigators that are coming up.
If I may add,
Please go ahead.
I agree with Dr. Money. I think it's how we fund research. I agree lots of support is needed for young investigators, but we need to adequately support trainees if we want to have a new pipeline of individuals to carry on that work. And so we need to be able to support people from training into their faculty positions and onwards so that those early investments yield the results that we can then translate into practice. And we need to make a better effort at funding research that takes us from learning about the results to actually making change at the policy level, because that's often where the findings that we do have that are important tend to fail.
And that could make us more competitive and allow us to bridge gaps with how other people are performing internationally. Dr. Valentine, this is MS month. I don't have my flower today. My daughter has it, actually. She had a lot of fun with it. I don't have it with me today. I should have probably brought another one. but you spoke of the financial impacts of MS. In my constituency office, I met with representatives of MS organizations in Quebec, and what I was told is that for EI, there should be a reform to reduce the number of hours to accumulate in order to have access to EI. This is something that we are pressuring the federal government to do to help people who are going through difficult times when it comes to their health. How would an EI reform, and this I should say that this EI reform would help women tremendously, but how would it help specifically those diagnosed with MS in order to tackle financial difficulties?
Yeah, thank you for the question. What we know about individuals who have MS is they often present with what we call relapsing, remitting forms of MS. So somebody can be quite well in one period of their life, and next month it could be a totally different story. So we've been asking for reform to reduce the number of hours to qualify for EI so that people can manage an often episodic form of their disease, get enough hours to be qualified for EI. So the request has been to drop the number of hours from 600 to 400. It's a real challenge for individuals living with episodic forms of the disease because they don't need the same benefits all of the time. Some individuals will progress and pull out of the workforce, but we know there's a very high percentage of individuals with MS that at some point in their life are going to be in need of support structures because they're just not well enough to contribute to the workforce. They don't want to come out completely. They don't want it to be a binary system in which you're in or you're out.
Thank you, Dr. Valentine. Next, Ms. Kwan, please, for 6 minutes.
Thank you very much, Mr. Chair, and thank you to all the witnesses and for sharing your expertise with this committee. I'm particularly interested in what work do you think can be done and what the government should do, particularly in looking at the issues through the lens of underrepresented communities. So, for example, in the racialized community, LGBTQ2 plus community, and I would even venture as far as to say for seniors who are often put in the back burner, if you will, especially as they age, and some of the health concerns, both on the research side as well as on the side of actually providing real, actual supports. To all the presenters, please.
Maybe I'll jump in, and I don't know if anybody else will make the same comment, but we have a real problem with information, data in this country. So I sit here as the CEO for MS Canada, and I cannot answer what the diversity of our population living with MS in this country looks like. I can give gender, which is fantastic to know that it's 3 times as many women as men. But after that, it's really difficult to answer the questions. To get data in this country that crosses provincial borders is exceptionally difficult. That will not be a surprise to you. That definitely causes us more time, money, and energy to get the solutions that we have today, as Ruth Ann has suggested, into the hands of the people that are going to put that information to work. So it's a really real barrier for us.
I'd like to pick up on that theme. What we know in many diseases, particularly as they affect women, is it's definitely overrepresented in racialized communities, in rural and remote communities. But we have a terrible problem in getting accurate data on really any health condition in this country that covers the whole country, that tells us where people live and what their cultural or racial background is, what's their first language, and so on. the lack of ability to link data within health authorities across the province and across provinces and territories is an enormous barrier to moving the dial in this area.
Well, thank you for that. So then, to address this issue, would you suggest then there should be dedicated funding targeted towards this data collection and research in this area? What would you say that needs to be done then? What is the number one priority that the government should undertake to address this? Dr. Money?
Sorry, I'm dying to jump in on this. Funding is always helpful, but to be perfectly honest, the barrier is legislation. We are not permitted to share data without enormously complicated agreements. And every single time we try and look at another thing, be it COVID, be it syphilis and congenital syphilis, be it whatever, we have to go through individual level new agreements to get permission to share what is actually de-identified data, but has some information on it, say, around rurality. So that's our biggest barrier.
Okay, so then to that end, the federal government should take a national approach to it and to coordinate this effort between provinces and territories so that it doesn't become, and through legislation, whatever it is needed, so that it doesn't become a barrier to addressing women's health. I'm seeing heads nod, so we will make sure that and that's your recommended, a recommendation as a priority item that the government should undertake.
Would be a big priority for me, that's for sure.
Dr. Valentine, did you have anything to add?
I was just going to ask Dr. Mary if she wanted to comment as a researcher who very regularly tries to get data across provinces.
Yes, so thank you for that. So I agree the regulatory barriers, and we know why they're there. It's important to protect the privacy of health information. Nonetheless, are complex. Unlike countries in Scandinavia, where you can have all the national data all at once through a single process. We, as Dr. Money said, have multiple processes, but even within provinces, I had one study where I needed 13 regulatory approvals to do one study in one province. So this adds to cost. It reduces the productivity that we have for the amount of research dollars invested. It limits our ability to do things that are relevant on a national scale. In addition, we have a fundamental data harmonization problem. We collect information differently in different regions about these key socio-demographic and diversity characteristics.
Well, thank you very much for that. I actually really appreciate it, and we'll make sure that I hope we can advance that as a recommendation from this committee. I want to ask a quick question. I just got a signal from the chair that I got 1 minute left. One of the issues that women often tell me is forgotten or is hard to diagnose, perhaps even, and it is endometriosis for women, and particularly young women, and they're in such pain. Any advice or action that needs to be taken to address that? Dr. Money?
Thank you for that question. And we do have research in this space looking at biomarkers, so markers in the blood to pick up endometriosis in its early stages. It can be diagnosed surgically, but requires a specialized center and individuals with expertise. But again, focused research in areas like this are making a difference. And I think if we can get to the point of non-invasive markers that makes it simpler in community to make these diagnoses, it will help these young women.
Thank you, Ms. Kwan. Colleagues, we have resources and sufficient time for one more round of questions from each party if the witnesses are prepared to stay for another 15 or 20 minutes. Does that suit? Great. Thank you. Ms. Roberts, please, for 5 minutes.
Mr. Chair, and I'm really disgusted in hearing that we can't share within provinces. Isn't it more important to save lives? I think it should be a recommendation that we change that legislation like ASAP because, you know, we're important. I think all of us women here would agree to that. So I have something I want to get my head around this, so please help me with this. What research has been done to discover why Canada has the highest number of MS individuals? How do we compare to other parts of the world, and what can we learn from best practices used from other countries? Dr. Valentine, do you have any comments on that?
Well, thank you for the question, and allow me to start, but I really will toss it to Dr. Mary. I like to describe MS as a perfect storm. What we do know is that it's a complex disease. There are 230 genetic loci that have been identified that are associated with the disease. And then if you stack on top of that environmental circumstances, a life course of an individual, and it is that perfect storm, then you tend to see the expression of the disease. What we know today is we could identify it much, much earlier, in fact, years earlier than we probably currently can today. We don't really know why Canada has got the highest rates in the world, but it's likely a combination of those factors of genetic predisposition and environmental circumstances that has led to that. If you look around the world, there's a northern sort of country band, a latitude band of the kinds of countries that do have the highest rates in the world. But I would ask Dr. Mary to comment as well.
Thank you for that. So as Dr. Valentine mentioned, we think of MS as you need an underlying genetic template that you're born with, and then exposures over the course of your life that lead to disease. If we think about who many of the first people were who settled in Canada, many of them have genetic backgrounds that are shared with other parts of the world with high risk, like Scandinavia, Western Europe, and the UK, for example. And then we can think about the environmental risk factors. We don't know all of them, but there are some that are common in Canada that are associated with risk: smoking, obesity, particularly in childhood, low vitamin D levels, which you see in northern climates where the sun is further away for much of the year, as well as infections such as Epstein-Barr virus infection. If we want to think about changing that, we need to think about trying to act on the risk factors we can change. Hard to change your genes, but we can take action to make sure people know that smoking is a risk factor for MS and work on trying to help people quit with both policy measures as well as education and targeted efforts to people who may be at higher risk because they're known to have a family member with MS or another immune disease. We can work on childhood obesity. Again, there are lots of policy levers around availability of foods that have sugar and fat and all of those things accessible to children and school programs. And we can look at studies where we can actually test whether interventions with vitamin D or trying to prevent or treat Epstein-Barr virus might prevent disease. And these may allow us to move forward in terms of reducing the risk of MS that we see. This is a critical issue. The number of people with MS is going up in Canada, not so much because the risk is going up, but because we're doing better at diagnosing people earlier and people are living longer. So the burden is going to continue to rise. It is really important for us in terms of the country's well-being for us to try and mitigate as much as possible the risk to future generations of developing MS.
Do you think that there will ever be a situation where we have the opportunity to develop a screening mechanism to stop this, well, maybe not stop it, but help identify it early in the stages of MS?
Yeah.
Yes, I think we are moving, if I may, Pam, in that direction. So we now understand that there are signatures of MS we're starting to pick up in healthcare use before people present with their first typical symptoms. And we know that we can see markers of brain injury during that period of time. There's new research, and this highlights the importance of research just last week, that identified a signature in the blood that might help identify people at higher risk. We need to narrow it down so that we can target investigations to people at higher risk. But those are active areas of research that would benefit hugely from additional investment. So because our early work tells us if we can intervene early before the typical symptoms of MS develop, we may be much more effective at preventing people from moving along that path. There are people with brain MRIs that look like they have MS, but they have no symptoms. We refer to them as radiologically isolated syndrome because it's just on imaging. There have now been 2 clinical trials that show us that if you treat those individuals, you can reduce their risk of going on to symptoms of MS over at least the first few years by 80 to 90%. This is dramatic. If we could identify people like that early, then we can potentially have an enormous impact. We're not yet able, due to the approvals process in Canada, to treat people who have radiologically isolated syndrome for that purpose. But these are things that we need to move towards to reduce the impacts of MS.
Thank you. Thank you. Yeah, no, we're almost at 6 minutes there, Ms. Roberts. Thank you.
Okay.
Over to the Liberals. Mr. Nakvi, please, for 5 minutes.
Thank you very much, Chair, and I will share my time with Mr. Pawlowski as well. I'll start with Dr. Valentine, with you. I had an opportunity to meet some incredible folks from MS Canada just a few days ago, as I was mentioning to you earlier, and part of our conversation that took place was around the prevalence of MS in women. And that came as a surprise to me. I had never thought about it in that terms. I was wondering if you can expand on that. What data and evidence we have in that regards? Do we know what are the causes? Are these environmental? Is it genetic that results in MS instances more in women than men?
And I'll start, but I will toss it to Dr. Mary again. I don't think we really know why it's so prevalent in women versus men. But again, it's going to come down to sort of that genetic milieu that a person has, that they're born with, and then the set of circumstances or risk factors. But Dr. Mary, perhaps you want to comment.
I think this points to part of what we heard from Dr. Money earlier. So there is what we call sort of a sexual dimorphism in the brain and differences in the immune system. So things like hormones will influence manifestations of disease. And so we don't fully understand why, but knowing those things are different, we can see that may then interact with genetic factors and some of the other environmental factors that lead to the disease. And this is not a unique problem for MS. There are many other, what we'd call immune-mediated diseases, where there's some immune dysfunction leading to disease, where women are more likely to be affected. So understanding that interface between the sex-specific biology and disease risk is really important to allow us to successfully target prevention efforts, as well as learning how to treat disease based on an individual's characteristics.
So just a follow-up question, Dr. Murray. Is there sufficient research taking place in Canada to determine those causes as it relates to women? In other words, is there more women-focused research in MS taking place right now, or more needs to happen to better understand the factors?
I think more needs to happen. I don't think this has been a focus of enough research in Canada or elsewhere in the world.
Thank you. Mr. Pawlowski?
The link between EBV infection and MS, how certain are we of that? Is there an EBV vaccine? I would assume it's not quite as easy as well. I think you mentioned that it was a necessary causal factor for multiple sclerosis. I would assume it's not so easy as, okay, we've got a cure, we vaccinate everyone for EBV. Is there a vaccine? How close are we to a vaccine? And is there that kind of causal certainty that we can take that approach?
So there's been a growing body of literature over a very long period of time that linked EBV to MS. I think that the sort of push in the field, the belief that this is really an important and the strongest risk factor that we might be aware of today, was a military database where they looked back and had biological samples and could look back 20 years, and it was the single viral indicator for everybody who ended up getting MS. So I think that has really pushed forward the EBV story. There are 3 EBV vaccines that are currently under development, one of which is an mRNA vaccine, like a COVID-type vaccine. Importantly, there's other antiviral medications, many of which are available to us today, that might play as important as a role as perhaps a vaccine will. I don't believe it's realistic to think that there's going to be a vaccine, should it become available tomorrow, that we then vaccinate the whole population. I don't think that's probably the most successful prevention strategy that we'll have available to us. But if you can imagine that you know that at-risk population that Dr. Mary just talked about, then maybe you can deploy where you know you've got an at-risk population, either a vaccine or an antiviral, particularly early in potentially the disease course. So I don't think there'll be one strategy at the end of the day. I think there'll be multiple strategies.
Thank you, Dr. Valentine and Dr. Pawlowski. Suite Madame Larouche pour 2 minutes et demie.
Ms. Larouche for 2.5 minutes. Thank you, Chair. One topic that we probably haven't heard about that much during the questions up to now, but Dr. Gupta, you spoke about it in your introductory remarks. You spoke about intimate partner violence and the consequences that IPV can have on women's health, whether we're talking from a psychological or physical point of view. More and more places across Canada are calling intimate partner violence an epidemic. Is this a good way of starting to draw a link between women's health and intimate partner violence and the consequences of such violence? I believe that there is not enough research on intimate partner violence, and that has an impact on the health system. This is a point that I really wanted to emphasize. 80% of healthcare workers are women. So we can't talk about an epidemic in the general population without talking about the impact of this epidemic on healthcare workers. Healthcare workers, that is the women who work in the healthcare system, are more likely than men to face violence from patients as well as from the families of the patients. So I think they are twice as vulnerable in this way, and we don't have enough data or research to tackle these. We don't either have systems to finance this research into these possible links. Dr. Money, I saw you agree. Do you have something to add?
I was just really agreeing with the situation that partner violence is definitely experienced to a great degree by women, not exclusively. And we see then the juxtaposition of other diseases on that vulnerable population. We see higher rates of HIV, sexually transmitted infections, other disease states. So it multiplies the damage and the problems. We have a great deal of difficulty in quantifying the partner violence because of the very nature of it, and women tend not to come forward. But more research into how to understand it better and obviously how to prevent it is critical.
Thank you, Dr. Money. Merci, Madame Larouche. The last word goes to Ms. Kwan, please, for 2.5 minutes.
Thank you very much, Mr. Chair. Just want to follow up quickly on my last question. Good to hear that there is perhaps more research and potentially emerging research coming forward. In the meantime, what should women do? Because often it's just sort of overlooked, and it's hard for the women to say to their physician, to look into the issue. So what can they do? What can women practically do at this point?
I think there's two sides to it. One is women need to be empowered with the understanding of what this condition is and how it can manifest, and then they can self-advocate. But on the side that I sit, where as an educator of women for women's health, for obstetrician gynecologists, primary care providers, and so on, I think we have very much spoken about this, need to increase the general understanding by practitioners of how this manifests and ensure that these women are taken seriously when they present with symptoms that may be a little bit nonspecific but can sometimes be very devastating. And we need to increase the number of practitioners in OBGYN who can do the current surgical diagnostic procedures that are needed until we get research into non-invasive options.
Thank you. Do you have time for another quick question? In terms of MS Canada, I note that in the presentation, with respect to the need for research and the call for a $50 million investment in research, I guess of the different recommendations that you want to make to the Canadian government, would this be your number one request by way of research investment?
What we do know is that less than 6% of the major MS research organizations from around the globe, both governments and, like mine, a not-for-profit organization, 6% is spent on prevention. I think it's an unprecedented opportunity in a debilitating neurological disease that affects women largely, that we could be preventing this disease in the next generation, probably 10 years. If I think about where we've gone in the last 15 years, to have gone from 3 to 20 disease-modifying therapies that have produced the kind of health outcomes that have reduced mortality by 30% and offset disability by 10 plus years, to be able to make those investments today is going to change the face of MS 10 years from now. There's not another neurological disease, I don't think, that in which you could make that claim with the evidence that's available to us today. So we're certainly asking the federal government to come in on that as a partner with a lot of concerned citizens who are going to give us some money to partner on that. So that's one of the specific requests that we've been making.
Thank you, Ms. Kwan. Thank you, Dr. Valentine, for allowing us to finish on such an optimistic note. This concludes the time that we have, and it also concludes the testimony that we intend to receive on this particular study. Next week we'll be giving drafting instructions to the analysts. Thank you for sticking with us and putting in the extra time. It will be of significant value to us, and we appreciate your patience and your professionalism. Is it the will of the committee to adjourn the meeting? I see consensus. We're adjourned.